session or symposium on exercise. My name is Jorge Ribeiro from Porto Alegre, Brazil. My co-chair is Dr. Nabil Ghorayeb from São Paulo, Brazil, and we will have a very exciting symposium this morning. We have excellent speakers who will cover different aspects of the field of exercise, prevention, and cardiology. We will start our presentation with Dr. Rolf Paffenbarger from the United States, then Dr. Antonio Pellicia from Italy, then Dr. Claudio Gil Araújo from Brazil, and finally Dr. Kenneth Cooper from the United States. The first presentation will be done by Dr. Rolf Paffenbarger, and he will talk about age-specific physical activity and other lifestyles that influence health and longevity. Dr. Paffenbarger, as you all know, is the father of exercise epidemiology, and we are very pleased to have you, Dr. Paffenbarger.
Thank you for your invitation for my appearance here. I'm delighted to be in Brazil for the first time, and I'm delighted that we have such good weather. My topic today relates to energy expenditure and other lifeways as they influence health, and I'll begin by reminding you that our age finds it difficult to come to grips with the need for physical exercise. We sit and ride rather than walk and climb. Our interest in sports is vicarious, not participatory. We pay heed to the elite athlete. If I may have the slides, please. We pay heed to the elite athlete rather than to the recreational athlete that we could become. Mechanization and automation, swift communication and transport, computer usage, and television viewing have abolished requirements for vigorous occupations and discouraged involvement in leisure time recreational activity. Despite these trends towards sedentary living, we now know that physical activity leads to improved physiological fitness and to health benefits, findings that should encourage us to be more active rather than less. Physical activity protects against the development of coronary heart disease, stroke, diabetes mellitus, obesity, osteoporosis, colon cancer, perhaps breast cancer, and we can say with considerable certainty that postponement of these chronic diseases through exercise represents cause and effect relations via alterations in intermediate mechanisms, not merely expressions of theory or artifacts of statistical selection. The question no longer is whether a physically active and physiologically fit way of life prevents disease and extends longevity. The question now is what kinds, how much, how intense, when, and for whom should physical activity be prescribed for optimal health and longevity. Now, this morning I will limit observations to just few portions of a prospective population-based study with numerical quantitative data on exercise, lifeway habits, and cardiovascular fitness as they might influence risk of all-cause mortality and cardiovascular disease mortality. The study that I want to describe includes some 50,000 men who aged average 17 or 18 years entered Harvard College or the University of Pennsylvania between 1916 and 1950. 50,000 men, about half of whom survive. Those still alive range in age from about 65 to 75. Now, the athletes of this time had about half the risk of developing coronary heart disease and dying from it up to age 50. Thereafter, there was little protection from any energy expenditure. Beginning in the 1960s, we sent questionnaires to surviving alumni at various points and followed these men for their physical activity, their diet, their exercise patterns of all kinds, of their habits of other nature, alcohol consumption, cigarette smoking, and so forth. And in the first set of observations from 1962 up through 1978, we looked at all-cause mortality. At baseline in 1962, 17,000 men from Harvard University, then aged 35 to 74, who were free of self-reported CHD. And these men were followed by their physical activity assessed in 1962. And the physical activity regarded flights of stairs climbed, city blocks walked, as well as listing the different sports and recreational activities that they engaged in, and compiling this into a physical activity index. As you can see, there is an inverse relation. The more active the men, the lower risk of death at all age classes, from the very oldest to the very youngest. Now, the number of years added to life is shown here in these curves of survival time. These years are truncated at age 80, and they represent a substantially lower risk of death throughout the time span of follow-up, 18 years, for men who were physically active. The area between these curves represents added years of life for the men most active as compared with the men least active. On average, these men lived 2 years longer if they were physically active and played moderately vigorous sports than men who were less active and did not play sports. Now, this is of some time back. This was a follow-up through 1978. I'd like to turn now to a more recent population, thinking about their lifeway habits today, following some 17, almost 18,000 men, 4,000 of whom died within a 16-year period of follow-up. We will follow them from 1972 through 1992, or up to the age of 90 years. Now, as you would guess, looking at age-specific categories, frequencies of physical activities differed. For example, 3/4 of the men aged 45 to 54 played moderately vigorous sports, and yet only 1/4 of the men aged 75 to 84 played moderately vigorous sports. And compiling the energy activities into a physical activity index, scored here as at 2,000 kilocalories per week, you can see that there is a steady decline in the proportion of men who met that standard. Cigarette smoking, of course, was still fairly prevalent, 15, 18%, but you'll notice that the older men, among the older men back in 1977, only 10% smoked. Almost half the number of aged 45 to 54, and the chances are that cigarette smoking limited the number who would get to the age of 75 if they still smoked. You can see that hypertension increased with age. Chronic disease increased very substantially from 10% of the youngest men to 37% of the oldest men. Now we'll look at rates of and relative risks of death by certain activities. Here, physical activity in walking in kilometers per week. Using walking less than 5 kilometers per week as the standard, men who walked 10 or more miles a week, 15 kilometers or more per week, had a 13% lower risk of death in this follow-up period as compared with men in the standard. Climbing stairs also shows a substantial improvement, a lowered risk of premature mortality. Men who climbed up 55 or more floors per week had a 14% lower risk of death than men who climbed less than 20 floors per week. Sports play is especially important for this group. These men, now aged 45 to 84 in 1977, men who played light sports had a 16% lower risk of death, and men who played moderately vigorous sports a more than a quarter lower risk of death than men who played none. Moderately vigorous sports we generally define as those that require 4.5 METs or more. That is, the amount of energy expended and the intensity of the energy expended at about 4.5 times that of the energy you are now expending sitting there quietly. Another way of measuring moderately vigorous sports as it influences death is recording the number of hours per week that men play these fairly active kinds of sports. Men who played 1 to 2 hours per week had a 21% lower risk of mortality. Men who played 3 or more hours per week reduced their premature mortality by 30%. Putting all of it together, again, as a physical activity index, men who expended 2,000 or more kilocalories per week had a 25% lower risk of mortality than men who expended less than 1,000 kilocalories per week. Other characteristics obviously influence risk of cardiovascular and all-cause mortality. Cigarette smoking in this population increased risk by 69%, hypertension by 33%, obesity, that is about the 1/4 of the men most obese for their height, had an increased risk of 10%, and having a chronic disease, that is coronary heart disease, stroke, diabetes, chronic obstructive pulmonary disease, or some other life-threatening condition doubles the risk of mortality in this 16-year period of follow-up. Now, it's important to think about age-specific activities, the age influence on health, on disease. Here we look at walking in the same distribution of distances for youngest men, older, still older, and quite old men. And you can see that walking doesn't do it for these younger men. Holding constant all these other lifeway habits, smoking, blood pressure level, weight for height, family history of disease, presence of chronic disease, eliminating those influences, walking alone is insufficient for men aged 45 to 54, but there is adequate protection in older men. Again, in climbing stairs, this is inadequate as measured by this device to prevent premature death. In fact, the men who climbed the most steps had the highest death rate. Sports play, however, is especially protective for younger men. Those who played light sports had about a 21% lower risk of death. Those who played moderately vigorous sports, those requiring 4.5 METs of intensity, had a 31% lower risk. Sports play, both light and moderately vigorous sports, is protective in each of these age classes available for study. Now, one of the big questions today is what happens when people change from a sedentary to an active way of living. These data, following these men, 17,000, again for 16 years, looks at the group, 18% of whom did not change their activity level between the 60s and the 70s. This is the standard. But men who increased their activities in that period had a considerably reduced risk of death, so that men who had increased their activities by 1,250 kilocalories or more per week had about a 1/4 lower risk of death than men who were unchanged. And in the opposite direction, men who decreased their activities increased their risk of death. Those who decreased their activities to 1,200 increased their risk by 1/3. The areas between these survival curves represent added years of living for the most active as compared with the least active. Important, too, is the finding that at each age class available for study, age 55 to 64, age 75 to 84, the men who increase their activity reduce their risk of premature mortality, and the men who decrease their activities increase their risk of early mortality. It's never too late to change, is what these data suggest. Now, if we put together the items of intensity and total quantity of energy expenditure, we see here at 3 age classes, the oldest, the middle group, and the youngest, that moderately vigorous sports, those requiring 4.5 METs of intensity or more, have a lower risk of death at each age class. It is especially important for each age class to include some kind of activity that gets your heart pumping, gets you to sweat a bit, and causes you to be a little out of breath. The differences are greatest for these oldest men, showing that up to about 2,000 kilocalories per week, it's very important to include moderately vigorous sports. Beyond that, it's not quite as necessary. Now, how many added years of life come from being active, from changing our habits, from not smoking cigarettes and so forth? These men, now age 77, following them up to age 90, would gain an extra year and 2/10 by being physically active. By playing moderately vigorous sports, they would gain about a year and a half. By not smoking cigarettes, they would gain almost 3. By remaining normotensive or being adequately treated for hypertension, they would gain a year and a half. Body mass index and chronic, not all that important, but avoiding these chronic diseases leads to an added gain of 4 years. Now for these men who changed, you can see very quickly that men who took up moderately vigorous sports would gain a year and a half. Men who stopped smoking, 1.8 years. Men who remained normotensive would gain a year. And for that group of men who took up moderately vigorous sports, who gave up cigarette smoking, who remained normotensive, there would be a gain of between 4 and 10 years, 7 added years of productive life. Now at this point, we do not know, as energy expenditure increases, what is the minimal amount of activity for improved health, what is the optimal amount for long life and avoidance of cardiovascular disease, or what is actually the hazardous level. That's why we continue to work on it, and I leave you with the message that people who are active and physiological fit will avoid serious chronic diseases, or at least delay them, and live a few more years beyond those years that one would otherwise live if they did not follow a healthful lifestyle practice. Thank you very much for your attention.
Thank you very much, Dr. Paffenbarger, for this excellent presentation. I would like to remind you that this is a joint symposium with the International Federation of Sports Medicine, and the president of the International Federation of Sports Medicine, Dr. Eduardo De Rossi, unfortunately couldn't come to our meeting, but he is very pleased to see that cardiology and sports medicine are getting together in this meeting, and most of us who work in both areas are also very, very pleased. And I also remind you that you may ask your questions at the end of the symposium by writing down the questions and sending to the table, or you can use the microphones on the floor. I would like to call now Dr. Antonio Pellicia From Rome, Dr. Pellicia has made major contributions on the understanding of the athlete's heart, on seminal studies on echocardiography, and he will present to us the impact of cardiovascular pre-participation screening in the prevention of exercise-related sudden death in elite athletes. Dr. Pellicia.
Yeah. Mr. Chairman, dear colleagues, ladies and gentlemen, I would like to focus your attention on the title that the organizing committee chose for me, that is related to the strategies for pre-participation cardiovascular screening and the possible impact that this screening may have on the prevention of sudden death in athletes. So I tried to summarize the main goals of the pre-participation screening that should be, number one, obviously, the identification, the early identification of those structural cardiac disease that are associated with a high risk of sudden cardiac death. And number two, also, the strategies to reduce the risk of disease progression, that is, deterioration of cardiovascular abnormalities induced by regular training and competition. So this is an unsolved problem because we should know, number one, what are the main causes of a cardiovascular disease inducing sudden death. That's a possible answer to this question. Here you see the results of a recent survey published on JAMA by Meron, in which there are the autopsy reports from 150 athletes that died suddenly during exercise. And as you can see, there is a variety of causes. However, the most common causes are hypertrophic cardiomyopathy and coronary anomalies, mostly congenital coronary anomalies in young patients. However, there are a lot of different structural cardiac disease, including mitral valve prolapse, arrhythmogenic right ventricular dysplasia, that is relatively new, less known disease, dilated cardiomyopathy, myocarditis, and Marfan's and aortic anorexia. So, having in mind this variety of causes, what could be the screening? In other terms, which is the best strategy we should follow for implement an effective pre-participation screening? In other terms, we should include history, physical examination, but also EKG, and when echocardiography. And we should take in consideration obviously, the ratio of cost efficiency that could be different in different countries for different populations. We should also consider the feasibility of this examination. We should also consider the implementation all over the country and for all the population. And not the last point, the legal implication of eventually discovered cardiovascular abnormalities. And obviously the screening should be different if it's reserved for small selected population of athletes, or it has to be implemented in the very large national based athletic population. So I would like to discuss with you very briefly these points. Number one, this is the approach of the American Heart Association. I think the approach that suggests that medical history and the physical examination is the best available and most practical approach for screening population is very relatively cheap, is feasible, and could be implemented in all the country. However, if you can see the results about this screening, here still there are data from Meron on the same article, we have data about 130 athletes that have been screened and died suddenly. So 150 had this kind of screening by history and physical examination. Among those, just one had correct diagnosis. That was Marfan. By chance, 15 others had a more complete cardiovascular screening, including usually EKG and echo, and not all, but 7, let's say 50%, had correct diagnosis. So it's pretty easy to conclude that the physical examination, the medical history lacks the power, the capability to identify reliably the cardiac condition associated with the sudden cardiac death. So next question is, what we can have if we add EKG to this screening? How the EKG may improve detection of potentially serious cardiac abnormalities. EKG is relatively cheap, is relatively easy to be implemented in the screening. I want to report you some data, preliminary data, about the capability of the EKG to detect cardiovascular abnormalities. This is a study that was intended to evaluate the EKG in athletes, that is, are the abnormalities of the EKG in athletes evidence of structural cardiac disease that are, in other terms, is useful the EKG for screening population, or those EKG are simply the consequence of athletic training. We examined about 1,000 EKG, and we found about 60% of the athletes with a normal EKG. However, 40% of the athletes showed some abnormality of the EKG. And from a clinical approach, we said that 14 had a really distinctly abnormal EKG, that is, an EKG strongly suggestive of cardiovascular abnormality. The other 26% showed also abnormalities, but less strongly suggestive of cardiovascular disease. Just an example. This is one of the EKG that we judged distinctly abnormal. You see, very huge increased QRS score, very deep Q wave, and so. Asymptomatic athlete, rower of the national team with an increased cardiac dimension. A very markedly enlarged left ventricular cavity, over 60, and a mild, relatively mild wall thickening within normal range. So this is another example. The markedly inverted T wave in all the anterior, lateral, inferior leads that are strongly suggestive for a cardiomyopathy, let's say hypertrophic cardiomyopathy. Again, soccer player, asymptomatic, no family history, no symptoms, nothing. The normal cardiac morphology, normal cavity size, wall thickness in the normal range, normal LV shape, nothing. So, in conclusion, among those 145 most markedly abnormal EKG, only 14 had evidence of structural cardiovascular disease that included mitral valve prolapse, aortic valve disease, dilated cardiomyopathy, hypertrophic cardiomyopathy. That is 10%. However, the majority had no evidence of cardiovascular abnormalities. Some, majority, 60%, showed increased cardiac dimension. That likely is the results of athletic training and competition in certain sports, like rowing. There is, however, a substantial subset, about 40%, of athletes showing markedly abnormal EKG and normal cardiac morphology and no evidence of a cardiac disease for its medical history, family history, physical examination, and so on and on. So putting all this information in numbers, we have that negative predictive accuracy of the EKG is pretty high, and positive predictive accuracy is pretty low. Just to be simple, if you have a very normal EKG, it's unlikely that the athletes may have a structural cardiovascular abnormality. On the other hand, if you have an abnormal EKG, this could be compatible with structural cardiac disease in few cases, and could be also associated with athletic training itself. So next question. To what extent echocardiography at this point may add useful information for the pre-participation screening? In the world, there are few examples of the screening done by echocardiography, including echocardiography as a routine. There are few reports in the literature, and likely because of the small number of the athletes that have been screened in this way, they actually did not show any major structural cardiovascular abnormality. That's for this reason they want to present some preliminary data from the institution, my institution. What is peculiar of my institution is that we do this program, this medical program, this cardiovascular evaluation by routine. That is, we include echocardiography by routine in all the athletes that came, regardless of any symptoms or any clinical indication for echocardiography. We have been doing this since the last 10 years, and in the next slides there are just a survey of the most recent years, from 90 to 97. About 4,500 athletes have been evaluated as a part of this medical program during these years, and among these athletes we found 30 people, 30 subjects, less than 1% with a cardiovascular disease that are associated with the risk of sudden cardiac death. Obviously, those people were disqualified. The majority of the people, more than 70%, were completely normal. About 25% required further investigation, usually for valvular disease or ventricular arrhythmias. Let's have a look at those people with structural cardiac disease at risk of sudden cardiac death. What we had? We had Marfan's and aorta annulectasia, we had hypertrophic cardiomyopathy, we had the myopericarditis, and to a less extent, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia, and so on. So, those diseases closely resembles the disease I have shown you in the first slides, resulting from pathological surveys. So, in other terms, we were able, by applying this protocol, to detect the diseases that are usually discovered at autopsy. And what has been the impact of the EKG and echocardiography in detecting those diseases? You see that EKG was very effective for hypertrophic cardiomyopathy and for dilated cardiomyopathy. However, echocardiography shows a superior accuracy, a superior sensitivity, because it was responsible for identification of the disease in 29, that is 97%, compared to 67% of the EKG. What about cost? This program that includes a facility, 20 or medical personnel, and a lot of technical instrumentation and training of the people and so, costs about $700 per athletes and applies to about 1,000 and elite professional athletes in a year. The cardiovascular program is a part of the more comprehensive medical, physiological, and the psychological program that is entirely supported by Italian National Olympic Committee, that in our country is like the Ministry of the Sports for other countries. And we have been doing this program in the last more than 30 years. They started actually in 1963, and so far we have an idea that we have evaluated about 22,000 athletes. During this more than 30 years, we disqualified 600 athletes, and we had 3 cardiac sudden death among those athletes. We had 3 sudden deaths only among the people that were disqualified for any kind of cardiovascular disease. Particularly, we had 1 WPW syndrome, 1 Marfan, and 1 arrhythmogenic right ventricular dysplasia. So the screening was effective in identifying and disqualifying the people that eventually had the risk of sudden death. On the other side, among the largest portion of the athletes that were considered fit and then qualified for sports, we had 2 sudden deaths. 1 after blunt chest trauma, that is likely an example of the commotion cordis, and 1 for stroke. In both instances, the pathological evaluation confirmed that cardiac structure was normal. So, in conclusion, the program, the cardiovascular evaluation program at the Institution of Sports Science, that is the program that includes echocardiography as a routine, proves to be feasible and effective for screening selected population of athletes, like elite and professional, particularly elite and professional athletes. However, as implicit economic limitation to be implemented in the overall athlete population. So we remind on the first slides, if you have a small population, you may be more efficient. If you have a very large population, possibly you may utilize the EKG that allows you a certain degree of diagnostic accuracy. Thank you very much for your attention.
The best exercise investigator in Brazil is from Rio de Janeiro.
It's a pleasure to me, as living in Rio, born in Rio, to receive all of you in this meeting, especially the foreigners and the participants of other states of Brazil. It's also an honor to share a roundtable with Kenneth Cooper, the father of aerobics. Yesterday morning we have a lovely walking activity with the Rio de Janeiro population in Copacabana Beach, joined by many of cardiologists in the meeting, to share a table with Ralph Paffenbarger, known by our friends as Paff, who is responsible for most of important data ever collected in epidemiology of physical activity, and by Antonio Pellicia, the one fellow from Italy, from the Italian National Olympic Committee, someone that if you have a problem with the EKG of one athlete, you would like to have for a second opinion. My topic at this morning, at this symposium, is a pretty hard topic. Is greater exercise testing useful before a physical activity increment in asymptomatic adults with coronary risk factors? This topic has called the attention of our media, unfortunately by a sad accident last week with one famous politician in Brazil. Before to start to discuss exercise testing, we may have to come back to mention what are the risk factors for coronary heart disease. I may report for the Bethesda conference, co-chaired by Valentin Foster here in the meeting, and they present 4 categories of risk factors. Category 1, they mention the most important, the second in relevance, and third and fourth. The fourth we cannot exchange very easily, some of them. With my partners in this symposium, we may disagree that physical inactivity is placed in category 2, and I think we should rephrase the slide using data from Stephen Blair, from Kenneth Cooper's lab, and from Paffenbarger's with Harvard alumni, saying that physical inactivity and low fitness should be placed in category 1 as risk factors for coronary heart disease. Let's start with some considerations in coronary artery disease. A very important editorial published in JAMA 1997 by Ambrose and again Valentin Fuster point out some relevant issues that I would like to leave with you this morning. In asymptomatic or mildly symptomatic patients with coronary artery disease, acute events are not predictable, only occurring in 15% case in a long follow-up. Besides that, we must recognize today that acute coronary events, mainly acute myocardial infarction, are unrelated to stenosis severity. Even if you have 50% stenosis, you may be or even higher risk sometimes, because this is a vulnerable plaques concept. The plaque can rupture, you'll have a thrombosis and a myocardial infarction. I borrowed this slide from a good friend, Victor Florica. They published this slide in internet. We can use it easily. Just to show you many data from different kinds of procedures that you can perform for functional evaluate the heart. And what you can see, a very common discussion, what is the sensibility and the specificity and the predictive accuracy, ROC curves, of exercise testing are not impressively high as an average. So maybe exercise testing, sometimes you miss some information. You must recognize that. But if you look at the guidelines for exercise testing recently published jointly by American College of Cardiology and the American Heart Association, they classify all the procedures in a given class. And they call class 1, that's something that should not be missed to be done. When they discuss exercise testing indication in a symptomatic subject, they do not feel any real good reason to perform in everybody. When they go for class 3, they suggest not to be done, they put routine screening of asymptomatic men and women. But they put in class 2B, that could be even sometimes useful to perform, for the evaluation of persons with multiple risk factors and for evaluation of some asymptomatic older men and women, especially if they have some relevant issues or conditions. Well, let's detail further what means evaluation of persons with multiple risk factors. That's our topic today. Class 2B, you have the usefulness and efficacy is less well established. Oh, that doesn't mean it's not very clear if you should do or not. There is no consensus on that. But unfortunately, I'm very sorry to look at the list of multiple risk factors, and I couldn't find physical inactivity again. Well, but let's leave like that. Consider if someone presents with multiple risk factors, they agree that sometimes could be useful to perform the test. Well, I would like now to put some original talks or ideas in this matter. Of course, when you look for exercise testing today, especially the EKG, you should consider Bayesian analysis. You should look for prior test risk, prevalence of the disease in the population. We have a lot of interesting epidemiological terms to come for post-test risk. It's also relevant to consider in EKG during exercise not only the magnitude of ST segment change, but when they occur and when they disappear. We have to discuss the measurement criteria. We have to discuss the slope. Is upsloping? Is downsloping? The number of leagues monitored is interesting to point out the last guidelines of American College suggest to come back from 12 leads to 1 lead in most of cases. And to put on the Bayesian analysis, that's a very important issue. Well, we may now divide the EKG exercise testing procedure in a past approach when you consider ST segment change at maximum exercise, either positive or negative. The current approach should be, is segment ST change related to intensity of exercise and during recovery, especially when you put the patient in a supine position. Magnitude and slopes are also important, as maybe hysteresis and ST heart rate relationship. We also must consider Bayesian theorem analysis and, of course, multivariate analysis. I think this is a major issue because we should not consider exercise testing as a synonymous of exercise electrocardiogram. This is a very misleading approach, a very limited approach. Why this? Because today is a wide literature showing that there are other adverse prognostic response markers during the great exercise testing that can be really looked for. Low functional capacity, high chronotropic reserve, abnormal blood pressure, either a modest increase or decrease in systolic blood pressure with exercise, and an increase in systolic blood pressure during recovery. If you look, there are further criteria that show adverse prognosis in people that present them. Low maximal aerobic power, low anaerobic threshold, high ventilatory equivalence presented at anaerobic threshold, abnormal O2 pulse curves, especially plateau or decrease close to maximal exercise, and is lower gas, ventilatory gas kinetics, and hemodynamic kinetics. Let's just clarify some of these points. Data coming from Kenneth Cooper lab, point out by Stephen Blair many years ago, clearly point out that low physical performance evaluated by different approaches, including recall questionnaires, have been directly related to cardiovascular disease and all-cause mortality, as Dr. Paffenbarger clearly showed with his outstanding data in Harvard alumni also. If you look at the Duke nomogram that predicts average annual mortality, looking for ST segment change, angina presence or absence during exercise, and physical capacity evaluated very simple by maths, I would like to make just a numerical example to give you an idea what is the importance of this issue. If you look at two cases, first one, ST segment deviation, none. Angina, none. Maximal physical capacity, 4 max only. They have annual mortality of 2%. But if you look at now, a subject with ST segment deviation of 2 millimeters, angina during exercise, none, but very clearly positive test for ischemic change. But he also has a 14 max as a maximum physical capacity. His annual mortality is just half of the previous case that does not present with ischemic change pattern during EKG and exercise. Are we always aware of these calculations? I think I would like to leave this point clearly with you. If you look for O2 pulse curves obtained by cardiopulmonary exercise testing, you can have, this is a normal curve response related to exercise intensity, and this is some suspected when you have a plateau in the last minutes of exercise, and this is the abnormally. Maybe this function is more dangerous for sudden death than just ischemia. Look at this, people with this response likely is in danger of death. If you look for blood pressure response, additional benefits of performing maximal exercise testing in asymptomatic adults is this one. Looking for very recent data also from Cooper Clinic's lab, we just published in the Journal of Clinical Epidemiology this year, we have that an exaggerated response to exercise is a strong predictor of future resting arterial hypertension. A world ratio of 3 Similar data we have seen along of the years in European literature using cycloergometry most of the time, where it's easy and you have higher arterial blood pressure response to exercise. If you look now, I would call the attention of you, the greater exercise testing could be very, very useful if you intend to start a physical activity program to perform a safe and correct exercise prescription. Exercise intensity can be better quantified and individualized using greater exercise tests, I would say preferentially cardiopulmonary exercise testing data, likely minimizing risk and maximizing benefit. This is pointed out in the American College of Sports Medicine Guidelines, 5th edition. What's our target with the, when we submit someone for exercise testing, maximal exercise testing? This is asymptomatic. We should look for different points now, I would say. And the major one is to perform a good exercise prescription. There is no doubt that just exercise is very good for health, but could be optimal if you know exactly what exercise should you do. The classical ways to prescribe exercise are based on maximal predicted heart rate. We can improve this a little using maximum measured heart rate. You can go even better with maximal estimated VO2, or this is fantastic if you have measured VO2, or look as if we perform with clicks, and why not with general population heart rate that happens during anaerobic threshold. So you can be able to detect a good target zone for heart rate during exercise. Well, I would add one additional benefit that I would call baseline determination. When you look for a patient that has you have a lab examination, you look at a nice hemogram, a nice hematocrit, and he comes 3 months later with a low hematocrit. You say, that may be a problem. You had a normal value 3 months ago. So sometimes could be very useful, potentially beneficial to know that subject there had a normal graded exercise testing in a given moment for further comparisons. If ST segment change appear after 2 or 3 normal tests, appear in the 4th test and the 4th year of following up, we may have more meaning on that just come for the first time. This is being done with many complementary examinations like mammography and other techniques for screening. Well, I think it's time to think that greater exercise testing is moving in direction to have a cardiopulmonary exercising test. Many patients present with exercise intolerance. Is likely to be due to physical deconditioning, but could be also due to cardiac cause, or even sometime in a very strong smoker prevalence population, could be due to pulmonary cause, or even better, or more complicated, I would say, could be a combination of all factors. Well, to summarize our presentation, I would like to point out how we look, in my opinion, we should look the exercise testing in asymptomatic individuals. First issue, is the functional capacity equal or higher than predicted for age and sex and gender? Is chronotropic response good? If he has a low chronotropic response, they may have a problem. Does inotropic response, especially when we had chance to look with cardiopulmonary exercise testing by O2 pulse, is a very good indicator, I guess, if something is going wrong or right. Blood pressure response, and I point out the issue of rest, exercise as a predictor of future hypertension, and recovery that may indicate patients with heart dysfunction. Anaerobic threshold, that's the ideal criteria to predict and to estimate and to suggest a heart rate target zone for physical training. Does it present exercise-related symptoms, dyspnea, chest pain, claudication? And finally, it proposally put in the final of our list is AKG ST segment, time of appearance and disappearance, its local magnitude, and special use of bias theorem will help us to understand is to avoid the disturb or to have a high number of false positives, especially in a woman that will very much disturbed by a change in EKG during exercise with no other changer at all. And look for cardiac arrhythmias. Well, that's the approach that we use, and we expect to put to you some ideas during this presentation. The final idea is don't forget to enjoy Rio de Janeiro. Thank you for your kindness and attention.
Name in Brazil is synonym of jogging or exercise for all the people. The physical exercise as an instrument of public health.
Well, thank you very much for your invitation to come back to Brazil. This is about my 20th time to Brazil, Dr. Paffenbarger, so I feel like I'm a karaoke. I've always enjoyed coming to Brazil and enjoy having my son with me at this time. Over the next few minutes, I want to talk about stress testing from an epidemiological standpoint, how it relates to longevity, and its cost effectiveness, that is, physical fitness. The first slide, please. We have at the Aerobic Center in Dallas several divisions. The Cooper Clinic is a diagnostic, preventive, and rehabilitative clinic where some 27,000 patients have come to the clinic from 1 to 27 times over the past 27 years. We now have a database at our research institute that has over 500,000 person-years of follow-up on these patients. All right, the criteria that we're using to determine level of fitness is an objective measure of time walked on a motor-driven treadmill with continuous EKG monitoring evaluated by computer. We've used for the last 27 years the standard bulky protocol, which is a standard speed of 90 meters per minute. The incline is increased 2% the first minute, then 1% each minute thereafter, and at least 98% of our patients will achieve their predicted maximal heart rate. All right, now we've been looking at the standard ischemic response as a measure of heart disease, looking at the ST segment depression. Now, if you get the classic ST segment depression curving down at least 0.08 millimeters in length, that is an abnormal stress test. Now, we've been looking at the predictability of an abnormal stress test in predicting deaths from coronary heart disease. This study has not yet been published. The data has just recently been submitted to the New England Journal of Medicine. So this is the first time that this data has been presented. Almost 26,000 asymptomatic men, 20 to 82 years of age, with a follow-up of almost 10 years per person. 217,000 person-years of follow-up. A total of 612 deaths, 158 died from coronary heart disease. 95% were white. The frequency of abnormal tests was 15% with risk factors, 7% without risk factors. All right, what were the standard risk factors? A cholesterol above 240, hypertension above 140/90, cigarette smoking, family history of heart disease less than 50 years of age, a fasting blood sugar above 126, and an abnormal resting ECG. What were the criteria for an abnormal stress test? At least 80% were classified as abnormal because an ST depression greater than 1 millimeter lasting 0.08 seconds or more. The other 20% were classified as abnormal because of angina, ventricular tachycardia, exercise-induced left or right bundle branch block, second or third degree heart block, a significant drop in blood pressure, sustained supraventricular tachycardia are the standard malignant ROMT PVC. I think the most important point I can present is this data. Those 158 men who died of coronary heart disease were broken down as follows. The relative risk of coronary heart disease death in healthy men with a normal stress test, no risk factors, it's 1. If they have a normal stress test, using the criteria I gave you, but 3 or more coronary risk factors, the relative risk of dying of CHD jumps to 10. Here's the important point right here. If the stress test is abnormal and they have no coronary risk factors, the relative risk of dying jumped to 20. With an abnormal stress test and 3 or more coronary risk factors, it jumped to 80. Now, we as cardiologists have been telling our patients they don't need a stress test if they have no coronary risk. My point is the abnormal stress test is probably the most important coronary risk. We also measure fitness for our epidemiological studies. We classify our patients into these categories based on the number of minutes they walk on the treadmill. This is an objective measure of fitness. We've had over 135,000 maximal performance treadmill stress tests. The bottom 20 percentile, men less than 30 years of age, walk less than 14 minutes. Here's the next 20 percentile, next 20, next 20. And if you make the top 20 percentile, the top superior is the top 5 percentile, it's these 2 categories. It is age adjusted, 40 to 49, 50 to 59, 60 to 69, 70 plus, and also sex adjusted. This is a criteria we've been using now for the past 27 years to monitor or determine levels of fitness objectively. Dr. Stephen Blair, Director of Epidemiology at our institute, followed some 13,400 healthy men and women for an average period of time of 8.6 years. Looked at their all risk of mortality and compared it with their treadmill stress test and published it in this article, November the 3rd, 1989, in the Journal of the American Medical Association. This article has been classified as a landmark study of the century, answering the question, how much exercise is necessary if your goals are health and longevity? It was picked up by all the major newspapers the next day. It was a reason why in 1992 that the American Heart Association, for the first time in 30 years, brought up something from the secondary coronary risk, that is inactivity, and made it a major risk along with high blood pressure, high cholesterol, and cigarette smoking. What did it show? Looking at men, totally sedentary, bottom 20 percentile, their deaths from all causes up here. The top 20 percentile, over 10,000 men followed for 8 years. Their deaths from heart attacks, strokes, diabetes, and deaths from cancer was down here. The drop-off from here to here was 65%. But 58 of the 65% occurred from going from this category to this category. So the first time, Dr. Blair said that we can classify people into 3 categories, not 2 categories of fitness. In the past, it had been aerobic fitness or sedentary. Dr. Blair said we can combine these 2 categories. This is aerobic fitness. These 2 categories, health and longevity fitness, and now have this new classification of fitness. The bottom 20 percentile, sedentary. The next 40 percentile, moderate fitness, or health and longevity fitness, and the top 40 percentile, aerobic fitness. So the very important point here is the best return on your fitness investment is not going from the very poor sedentary category to the excellent superior category. It's going from the very poor category up to the next category. Minimal increase in physical activity gives you an exponential return. All right, that was our first study. The second study was published in July 1996 in the Journal of the American Medical Association, in which it brought up a very controversial subject. All week in Brazil, I've made this statement, that you're better off smoking cigarettes and achieving a high level of fitness than being totally sedentary and a non-smoker. Where did that data come from? From this article, in which we followed 27,000 men for almost 10 years and looked at the sedentary group, moderately fit, health and longevity fit, aerobically fit, and those who had no coronary risk factors, cigarette smoking, high blood pressure, high cholesterol. And you can see from this slide that if a person has all three of these coronary risk factors, they still have a death rate that is lower than people who are sedentary and have no risk factors. In no way am I endorsing or supporting cigarette smoking. I'm trying to show you how dangerous it is to be sedentary, according to our studies. The second thing I've said this week is it's better to be overweight and fit than underweight or normal weight and sedentary. And again, that's based on a study we published in the Journal of Obesity in 1995, in which we followed over 25,000 men, 8.5 years follow-up, 673 deaths, and looked at their body mass index. And look what we showed. First of all, those less than 27 BMI, 27 to 30 BMI, or above 30 BMI, look at their risk factors. Everything is perfectly in line. The cholesterol goes from 5.4, 5.7, 5.8, it goes up with obesity. HDL cholesterol goes down with obesity. Triglycerides go up with obesity. Glucose goes up with obesity. The resting systolic blood pressure goes up, and the resting diastolic pressure goes up with obesity. All right, that's what you'd expect. Obesity is a major coronary risk factor because of how it affects the other risk factors. And look at this slide. Again, low categories of fitness, bottom 20 percentile. This is health and longevity fitness and aerobic fitness. And that category in which they were above 30 BMI, but still aerobically fit, had a much lower death rate than people who were poorly fit, but totally sedentary. That's my point. You're better off being overweight and exercising than you are being normal weight and sedentary. All right, we're talking about the public health value of fitness. I want to show you one other very interesting study in which we looked at over 10,000 men and women, examined our clinic over a 19-year period, and their fitness was assessed by their time on the treadmill, and they completed a mail-back questionnaire. We wanted to see, as people age, is their functional ability related to their level of fitness. This has great financial implications, because if older people can be physically active and take care of themselves, they will cost us less. So we ask these participants, are you able to do the following? Household work, daily living, personal care, light, moderate, strenuous activity. And then we looked at their low fitness, health and longevity fitness, and high fitness versus their age, 40 to 44 versus 70 plus, and the number reporting that they had at least one limiting activity. Those who were 40 to 44 years of age, 1/5 in the bottom category of fitness, had some physical limitation. You've got to go all the way out to the 65 to 69 year age group before you see the same number of older people that have limiting activities. That's true for both men and women. If I can keep these older people physically active, moderate to high level of fitness, I can keep them independent for a long period of time, and I can keep their cost of health care down. Do we actually have any data to document that? Yes, we do. And we can show that you can reach aerobic fitness by running 3,200 meters in less than 20 minutes 4 times a week. You can get the top category of fitness, aerobic fitness, by walking 4,800 meters in less than 45 minutes 5 times a week, or participating in aerobic exercise dance class for 45 minutes 4 times a week. But you can be aerobically fit and unhealthy. The late Jim Fix showed us that. But what does it take to get moderate fitness, health and longevity fitness? According to our standards, it doesn't take that much. Walk 3,200 meters in less than 30 minutes 3 times a week. I can't walk that fast, you might say. 3,200 meters in less than 35 minutes 4 times a week. Or 3,200 meters in less than 40 minutes 5 times a week. Or 4,800 meters in less than 45 minutes twice a week. Aerobic dance, 45 minutes twice a week. As I travel the world, I never see as many people exercising as I do here in Brazil. It's exciting to be out there yesterday morning with 10,000 people doing their Cooper at Copacabana Beach. Many people, 60, 70, 80 years of age, out there walking. Why? Did you ever think about that? Because of the quality of life they are enjoying. They aren't concerned about their health, their longevity, their heart disease. It's the fact when they exercise, they feel good. But finally, is there a value economically for you people associated with the government in recommending fitness? We followed 6,600 men for 11 years. They were healthy because they had any of these problems. They were not included in the study. And then we looked at their coronary risk based upon their time on the treadmill. Now this is fascinating. The bottom 25 percentile, next 25, next 25, next 25, based upon the minutes they walked on the treadmill. 12 minutes, 16, 20, 25 minutes. Their age was the same, 45, 45, 44. And their body mass index, perfectly in line. Those who were poorly conditioned, 28, 26, 25, 24 for those in top condition, BMI. Cholesterol, again, perfectly in line, 220, 214, 208, 201. HDL cholesterol, exactly as you'd expect, the higher, the more highly conditioned, 41, 43, 46, 51. That shows you the value of fitness in coronary risk factors Look at their triglycerides. 164, 137, 118, 90. Diastolic pressure, 82 down to 78. Systolic pressure, 123 down to 120. Fasting sugar, 99 down to 97. Current smoking. All right, then we looked at the number of times they had to see a physician during the year based upon their level of fitness. Those who did not see their physician, of course, there are only very few percentage in that category. If they were poorly conditioned, high condition, the highest percentage. Saw the physician one time during the year, not much difference. But they saw the physician 2 to 5 times a year. Look at the drop off there. These people are the poorly conditioned people. These people are the highly conditioned people. You begin to see that trend. Number of times they see their physician. But now go up to 6 to 10 times per year. And look at the relationship there. They see their physician more than 10 times a year. A perfect relationship. And every physician visit in our country costs at least $50. Substantial difference there. All right, then look at the number of hospital days based upon fitness. 1 to 3 days, no real significant difference. But 4 to 7 days, you see that same trend. And once you get past 8 to 14 days, it becomes quite dramatic. So I can show you the people who are fit, top category of fitness, are not spending as many days in the hospital. They're not seeing their physician. And the difference in cost expenditure for hospital stays and doctor's office visit between the poorest category of fitness and the top category of fitness was 63%. That, ladies and gentlemen, shows you the economic value of physical fitness. So I hope during this brief presentation I've made you think about the role of stress testing, how valuable it can be in predicting longevity and deaths from heart attacks. Hope I've been able to show you a perfect correlation between body mass index and risk factors, and a perfect correlation between measured levels of fitness and coronary risk factors, and finally the cost effectiveness of being physically fit. Thank you for your attention.
And we have at least a few minutes for discussion. I would invite the audience to write down their questions or to use the microphones on the floor to address the speakers. And I will start by asking Dr. Paffenbarger on a particular aspect of his presentation. You showed us some data suggesting that for a middle-aged man around 40 years of age, exercise should be done at a higher intensity for them to get benefit. And that goes is a little different from the current guidelines in which we recommend lower intensity exercise for the whole population. I would like you to elaborate on that finding.
I'm talking about a series of observations on Harvard College alumni, well-educated, bright, affluent, health-oriented individuals. The younger men, aged 45 to 54, followed up to age 60, gained a small amount of benefit from simply walking or climbing stairs, but they gained considerably more in terms of both reduced risk of cardiovascular disease, lowered rate of cardiovascular mortality, and lowered rate of all-cause mortality, that is, death from stroke, cardiovascular disease, COPD, diabetes, if they engaged in moderately vigorous or vigorous sports. In older age classes, it looked as if it took less physical activity, activities of less intensity, to gain the same benefit.
Yes, please use the microphone and identify yourself, please.
Edmundo Novaes, Rio de Janeiro. Eu vou fazer minha pergunta em português. Pedir ao Dr. Jorge que fizesse a tradução. Eu gostaria de saber da mesa se os dados apresentados, eles não podem ter uma outra leitura, uma leitura do tipo: os indivíduos naturalmente saudáveis, com menor incidência de patologia, diagnosticada e que estão se sentindo bem, se eles naturalmente não vivem mais, porque não têm doença, e naturalmente são mais ativos, diferentemente de se considerar que a atividade física é a responsável pela longevidade dos indivíduos, dos dados apresentados.
I think I will address this to Dr. Cooper, and basically the question is, what would you think the bias would represent of people being naturally fit when you consider physical fitness as your marker for risk assessment? So he suggests that maybe people who are naturally fit, they already live longer and they have less risk factors. And that would be interesting also to comment on the difference of using physical fitness as a marker instead of using physical activity. Because we saw here one way of looking epidemiology of exercise, first physical activity, and then with Dr. Paffenbarger and Dr. Cooper presented physical fitness, which are different ways of evaluating these studies.
Yes, that is certainly true. And Dr. Paffenbarger and I are measuring two different things. In fact, some studies indicate that the correlation between physical activity questionnaires and time on the motor-driven treadmill, which is a measure of physical fitness, the correlation at times is not that good, 0.3 to 0.4. We have found that in our studies that we do ask the people that come to our clinic what their physical activity consists of, and then do try to correlate that with their treadmill times. And we have a higher correlation. Now this is anecdotal, I can't document this yet, but it appears to be a higher correlation between activity questionnaires as people fill out when they come to our clinic and their time on the treadmill, perhaps because they know they're going to be stress tested. And if people fill out a questionnaire, unfortunately, at times they give you the answer they think you want, they exaggerate, they don't remember, and sometimes they just outright lie. So that's been an ongoing question over the years. Are we measuring activity or measuring fitness? And then is our study biased because people coming to our clinic are basically a higher level of fitness? Those are all good questions, which I can't give you the exact answer. But I think that we as objective professionals, if we can use an objective measure such as fitness, and it correlates so well with these coronary risk factors, deaths from all causes, and the things that I've mentioned, we'd be foolish not to ignore that. So I don't think that the bias of just being an athlete at birth is affecting our data that much.
I think Dr. Paffenbarger was quoted. Would you like to comment?
In terms of what we can do on a population basis in assessing the level of fitness, the amount of activity, it's much simpler to ask people how active they are than it is to get them to get on a treadmill, and it's less expensive. The observations on physical fitness comprise an estimate of maybe 25 to 40% of fitness that is inherited. The genetic influence of fitness is generally estimated to be 1/4 to 40%. It is important, I think, to get people to realize that physical activity is something they can do. achieving physical fitness comes only from being physically active. There's no thermostat we can set to increase our physical fitness, but there is the opportunity to become more active in our everyday life, on the job, in our leisure time, to improve fitness. So both fitness and physical activity, a status and a behavior, are strongly related to a reduced risk of important chronic diseases. And you as cardiologists, you as health-oriented people, need to get to assess in your patients, in your family, in your community, how active people are. And those of you that have the added advantage of assessing their fitness level have a better predictor of risk of certain chronic diseases and ability to estimate the pleasantries of a long life.
I have a question for Dr. Pellicia. Someone from our audience would like to know if you find someone with hypertrophic cardiomyopathy, which are your current recommendations as for exercise?
The first question with hypertrophic cardiomyopathy is the diagnosis. Sorry. Diagnosis, because diagnosis hypertrophic cardiomyopathy in athletes could be difficult. Could be difficult because the athletic training may itself cause a kind of hypertrophy. So you must be sure about diagnosis. And a certain degree of reassurance could be done from a series of findings that are morphological. And morphological findings include mostly an asymmetric distribution of left ventricular hypertrophy that could be in dimension in a range also of 13, 15, 16 millimeters, so it could be confusing with the physiological hypertrophy. But the key point is enlarged cavity size, normal symmetric. Sorry. So in physiological hypertrophy, you have an enlarged cavity size, you have a mild degree of left ventricular wall thickening with a symmetric distribution of the thickening. Instead, in hypertrophic cardiomyopathy, you usually have a more marked degree of thickening and an asymmetric distribution of the thickening. So morphologically, there is the chance, you have the chance of distinguishing these two different entities in a lot of cases, but not in all. In other cases, you should rely on different approaches, including deconditioning, and we saw with deconditioning that left ventricular hypertrophy in athletes does regress, does reduce. In terms of 2-3 months, you may see reduction of wall thickness in a range of 2 to 3 millimeters with real deconditioning. And obviously, you should do also the family investigation, because hypertrophic cardiomyopathy is a genetic disorder. So you have a great chance to find other relatives with the same disease. There are other criteria like EKG, Doppler, but the two most reliable criteria are deconditioning and family history. Then when you got the diagnosis,
let me just interrupt you for a second before you move on to the exercising. Do you find diastolic dysfunction a reasonable marker?
That's a usual question. In case of the athletes with a physiological hypertrophy, the left ventricular filling is always normal. Always. There is no athletes with abnormal filling and physiological left ventricular hypertrophy. In the other case, that is hypertrophic cardiomyopathy, you may have an abnormal feeling, but in selected cases, you also may have a normal left ventricular feeling. So when you got the real diagnosis, when you have the real disease, there is no doubt about the diagnosis. There is a consensus at this moment for disqualifying those people from intense athletic activity, intense and regular athletic activity, because of the risk of sudden death. Actually, we guess that not all the patients with hypertrophic cardiomyopathy may have the same risk of sudden death. In fact, there are subset of these patients that have been doing exercise for a long life and they have been diagnosed just in the advanced age. So, however, just because at this moment we don't have a reliable criteria for risk stratification in this patient, there is a consensus to disqualify those patients from regular athletic activity. And that's it.
Thank you very much. We do have more questions, but unfortunately our time is out, and I would like, on behalf of the Executive Committee of the World Congress of Cardiology, on behalf of Dr. Ghorayeb, thank the speakers and the audience for your presence. Thank you very much.